Dear all, I am Alex Soriano, an infectious diseases physician working in hospital clinic in Barcelona. And today I have been invited to share with you my experience and my knowledge about a new beta-lactam that has a very promising usefulness in the management of community-acquired pneumonia patients. And here you can see the title of my lecture, and these are my disclosures. These are the 4 points that I wanted to cover today. The first one is the etiology of CAP in the 21st century, and particularly to discuss about which is the role of bacteria and viruses nowadays. There are some papers recently published that it would be interesting to discuss together. Second is the empirical treatment for community-acquired pneumonia. As you know, recently the American Thoracic Society has published the guidelines, and where they are recommending a macrolide associated with a beta-lactam or a fluoroquinolone associated with a beta-lactam for the treatment of severe community-acquired pneumonia. But also we will discuss how to identify when a patient fails when we start with one or other strategy. The third point will be outcome of CAP, but according to the clinical experience that we have with Ceftaroline or with ceftriaxone, which are the differences between these two new beta-lactams, and which are not only in terms of mechanism of action, in vitro activity, but also the impact of these mechanisms on the clinical evolution. And finally, I think that it's very important to discuss the relevance of Staph aureus as one of the important pathogens, although not so common, but a very severe pathogen associated with community-acquired pneumonia in particular circumstances, and how to cover and how to do the best coverage for this pathogen. So in line with this, we're going to start with the first point, how the etiology of community-acquired pneumonia has changed over the years. This is a paper that was published relatively recently in the United States, where the authors analyze the prevalence of pneumococcus in pneumonia from the 70s to 2015. And as you can observe, the data in the US suggests that there has been an important decrease in the prevalence of pneumococcus. However, this is something that happens in the US mainly, but it was not the case for Europe. And as you can see here, the prevalence of pneumococcus remains as the most common pathogen in Europe. And the authors suggest that maybe the difference is because the rate of pneumococcus vaccination is higher in the US than in Europe, maybe because there is a decrease in the cigarette smoking rates. Well, maybe both are influencing. But just as a comment, there have been one paper published in Clinical Infectious Diseases in 2017, where the authors, one from Houston and one from the CDC, they observed a high prevalence of viruses. I mean, 27% of the pneumonias from the community acquired were caused, according to these papers, by rhinovirus, coronavirus, human metapneumovirus, and they suggest that maybe community-acquired pneumonia is more often caused by a virus. Of course, nowadays with coronavirus, with new coronavirus, of course, the prevalence of coronavirus in pneumonia nowadays everywhere around the world is the leading cause, of course. But as you can see here, and coming back to the pre-coronavirus era, the situation in Europe is completely different. I mean, no viruses or no so prevalent was the virus's etiology. And what happens here, I think, of course, when they analyzed the bacteria, it was more or less the same for all the areas, about 30%, between 15 to 30% of bacteria, including mainly Streptococcus pneumoniae, Haemophilus, and Staph aureus, as the more prevalent pathogens. But what happens is that bacteria are analyzed according to the standard cultures and to standard samples. And it's very interesting to review this paper published in Clinical Infectious Disease again in 2016, where the authors analyzed using molecular testing, I mean real-time PCR, that included 26 different pathogens, including the most important bacteria, including also pneumococcus, Staph aureus, gram-negatives, and finally also molecular testing for respiratory viruses. And this is a study with 323 patients, the majority of them from sputum. And the first conclusion is, okay, viruses represent 30% of the patients, but when they analyze in combination also bacteria, only 5% of the patients with community-acquired pneumonia had only viruses. All the rest have a combination of bacteria plus viruses. The most prevalent bacteria, as you can see here, 81% of the cases, is the ones that I'm showing you here. But first of all, why this difference between molecular testing and microbiological testing or classical techniques? Well, because in 50% of the cases there was a correlation, but in 50% there was no correlation, positive PCR, but negative culture, because mainly a prior antibiotic therapy. The majority of the pathogens were, as expected, Haemophilus, Streptococcus pneumoniae, Moraxella, E. coli, Staph aureus, and Klebsiella pneumoniae. But interestingly, they observed that in a series where 12% of the patients require ICU and the mortality was 6%, so something that we have to consider. It's very interesting also from this paper to see that particularly for Streptococcus pneumoniae, those patients, they were able to count the bacterial inoculum from the beginning, thanks to the use of a real-time PCR. They observed that when the inoculum of bacteria was very high from the beginning, what happens is that this patient had a higher ICU admission and also a higher mortality rate. And this is important because we know that patients with old age, patients, fragile patients with comorbidity, etc., they have a higher mortality rate, but also those patients with high bacterial inoculum from the beginning, they have a higher ICU need and a higher mortality rate. And according to that, what we need in both situations, in fragile patients, as well as in those patients with high bacterial inoculum, these patients require a very potent and bactericidal antibiotic. And this is an important concept. We know that current tests, when we do perfectly well, like for example, sputum, and the sputum has a good quality, and this is a very recent paper published in Clinical Infectious Disease just a couple of months ago, they observed that when they consider all the pneumonia cases, only in 26% of the cases, as you can see here, the sputum provide the information about the etiology of pneumonia. However, if they select among those in whom a sputum sample was obtained, it increases to 36%. And if in addition, this sputum has a good quality, then the rate of etiology was obtained in 73% of the cases. So these authors are suggesting that we have to encourage our patients that are admitted to the hospital to produce a sputum, because in good hands is a cheap test and provides information, quite reliable information on the etiology of the pneumonia. But I wanted to address one point, that it's the importance of Staph aureus. When we have to suspect a Staph aureus in community-acquired pneumonia, well, there are several risk factors. And in terms of a Staph aureus, you can find this information in a Mensa guide for antimicrobial therapy, that it's in iOS or Android application that you can find it. Here you will find, among many other information, that the risk factors for having community-acquired pneumonia by Staph aureus include mainly influenza virus infection. Of course, this is one of the leading factors. Second, the intravenous drug abusers, chronic renal failure, particularly those with hemodialysis, diabetic patients, particularly insulin-dependent patients, and other patients, particularly when we have a patient with a severe pneumonia that has leukopenia, necrosis, cavitation, and frequently associated with the skin abscesses, we have to suspect on a Staph aureus producing Panton-Ballantyne leukocidin. This is not a quite common entity, at least in Spain, but it's something that we have to bear also in mind. Why Staph aureus and influenza is so dreadful combination? This is because, as you know, influenza is affecting clearly the mucociliary function. And this mucociliary system that we have here on top of the epithelia is responsible to clear the bacteria. But influenza is destroying the system, so it allows bacteria to enter and to progress through the respiratory epithelia. And finally, this is favoring the invasion of the bacteria and inducing pneumonia. We know very well this in patients that develop more than 5-7 days of fever with influenza. Finally, we have to suspect that the patient has a co-bacterial infection. But what happens is that we know well that the virus, in this case, influenza viruses, enters and infects the epithelia cells, but then needs to go out of the epithelia cell. And in order to go out, needs this enzyme, the neuraminidase. Neuraminidase, what it's doing is to cut this sialic acid, and then this allows the virus to be released from the epithelial cell and to infect another cell. Normally, for example, neuraminidase inhibitors like oseltamivir, what are doing is blocking this release, yeah? But Staph aureus is producing sialidases that are doing this work. So for this reason, the combination of Staph aureus plus influenza virus is so dreadful combination, and in general is associated with a higher mortality rate. Going into the second topic, going into the second main point, is the ATS guidelines. As you know, the recent ATS guidelines recommend for severe pneumonia the association of a beta-lactam plus a macrolide or plus a fluoroquinolone. Which one better? Let me start with my experience. We collect prospectively all patients with community-acquired pneumonia and documented bacteremia by pneumococcus. And what we observed from 1991 to 2016 is that the mortality rate is the one that you can see here, more or less about 10% mortality rate. But when we analyze which are the main risk factors associated with higher mortality, it's evident that age, older than 65, cirrhosis, but also other comorbidities in other series are also associated with higher mortality, and of course, septic shock. And these are increasing significantly the mortality. But the only variable that it was associated with a less mortality rate was the association of a macrolide. Why macrolides are so effective in reducing the mortality, at least according to our data? Well, this is preliminarily not so evident, because we know that when we combine penicillin or cefotaxime plus a macrolide, what happens? Well, in monotherapy, they are so bactericidal. You can see here a decrease, an important decrease in the total amount of bacteria after 6 hours of exposure to penicillin or cefotaxime. However, when we combine both penicillin plus erythromycin or cefotaxime plus erythromycin, what happens is that they are antagonistic indeed, less reduction in the total amount of bacteria. Then why this combination is better? Well, if we look at the pathogenesis of pneumococcus, we can see in this model, in this animal model, that those animals that were infected by pneumolysin-producing strain versus those animals that were infected with a non-producing pneumolysin strains, it's evident that pneumolysin is very important in the pathogenic mechanisms. A higher amount of bacteria in the alveoli and a higher amount of bacteria in the blood of those animals that were infected with the pneumolysin-producing streptococcus. Pneumolysin is a toxin that is produced by pneumococcus that has a very potent cytolytic activity and complement activating activity. And by doing so, pneumococcus is significantly more pathogenic. And what happens is that when we look at in vitro, what happens when we expose pneumococcus to, for example, clarithromycin, it's evident that the total amount of pneumolysin, here we have the amount of pneumolysin, and this is what happens when I start with clarithromycin, and by increasing dosages, we are significantly reducing in 24 hours the total amount of pneumolysin in the media. However, this is not what happens with beta-lactam. This is ceftriaxone, and we can see that even increases a little bit the total amount of pneumolysin. So as it happens with the Streptococcus pyogenes, when we combine clindamycin with a beta-lactam, although they are antagonistic, the outcome of necrotizing fasciitis is better when we combine with clindamycin. And maybe this is the same thing as it happens with pneumococcus and the pneumolysin production. Of course, there are other advantages of macrolides that we know well in terms of anti-inflammatory properties that I'm not going to enter in details. For sure, you know well. There is another aspect that we consider also to prefer a beta-lactam plus a macrolide instead of quinolone. This is the data from my institution along 60 months. And this is the prevalence of different items. The green one is the levofloxacin prevalence, the prevalence of use. In red, we have the prevalence of levofloxacin plus meropenem. And in blue, the prevalence of multidrug-resistant Pseudomonas. And what happens is that every time we have a peak, normally in winter, in the consumption of levofloxacin, then we have afterwards, 4 months later, a peak in multidrug-resistant Pseudomonas. And here you can see that it happens quite regularly, and indeed this was statistically significant. So we prefer to avoid the use of quinolones in the hospital. If I discharge a patient home, then it's comfortable once daily, and we're using quinolones outside. But inside of the hospital, we prefer not to use quinolones and to provide the patient with a beta-lactam plus a macrolide. And how to evaluate my patient? Once I started empirically with a combination or whatever you decide, it was defined many years ago, 1998 in JAMA, the criteria that the name is the HALM criteria that include the evolution of temperature, heart rate, systolic blood pressure, respiratory rate, percentage of oxygen saturation, and mental status. And what the authors defined was that those patients that achieve these parameters, we can define them as a stability, as this patient is stable. But how fast should be this clinical stability? And in chest, this important group working in pneumonia for so many years, defined that the stability, the early stability, the one that it's obtained within the first 3 days, it's very important for the final outcome of the patient. While those patients that achieve this stability later than 3 days, they have significantly more complications in the future. Indeed, in this paper, they compare those patients that achieve early the stability or late the stability. And they evaluated the rate of readmission, significantly higher in this group, readmission, but specifically by problems associated with pneumonia, higher, and death directly related with pneumonia, again, here in this group. This analysis is of interest because what we need is antibiotics that get my patient to the clinical stability as soon as possible, and particularly within the first 3 days. This is of great interest, I think, and we will discuss a little bit afterwards. Because the second question is, okay, I prefer a macrolide in combination with a beta-lactam, but with which beta-lactam? I mean, cefotaxime, ceftriaxone, or ceftaroline? Well, let me start first with some data, very recent data from a Sentry program that is working around the world, and they celebrate 20 years collecting data. And they published this information about pneumococcus, the susceptibility rate of pneumococcus within these years. I'm here showing you data from Europe and from North America. And they observed that for ceftriaxone, the MIC50 is, we can say, quite low, but the MIC90, as you can see here, is about 1. 1 is, we would say, intermediate susceptibility for ceftriaxone, yeah? And this means that about 10% of the strains have an MIC of 1. Which is the impact of this on the outcome of patients? Well, let me show you first the situation in my institution. This was published last year. And this is from very early 90s, almost until today. And this is the prevalence of strains, of pneumococcus strains with an MIC of 1. And as you can see here, there was a significant decrease over this period. But recently, again, we have a high prevalence, I mean, a prevalence about 13% of pneumococcus with intermediate susceptibility to cefotaxime, something that it has been maintained not in the paper, but here I'm showing you that it is about 13% again for these 2 years, 18 and 19. And if you remember, my mortality rate was something like that. As I mentioned you before, it's about 10%, but interestingly, the lowest mortality was obtained here. It's true that in the analysis, the risk factors associated with 13-day mortality were age, septic shock, and comorbidity, as usual. And so apparently, the MIC was not associated with a higher mortality. But if we look at the details, the mean age of the patients with a high MIC, they have also an older age, 68 versus 59 age, those with a high MIC. So apparently, and according to our data, probably there is some confusion, but people with higher age, they have a higher prevalence of high MICs, and maybe this is impacting also in the efficacy of the cephalosporins. So which are the differences that are of interest to highlight for this new beta-lactam, for Ceftaroline? Here I introduce you Ceftaroline. This is a standard cephalosporin ring here, the standard beta-lactam ring here. And from this side of the molecule, it's as many other cephalosporins with activity against gram-negatives, etc. But the importance of this molecule in terms of the big difference with other beta-lactams, that is the activity against MRSA, all the differences in this site. So remember this site, this radical in the carbon 3, because it makes the change for this new beta-lactam. But before entering in the details of the anti-MRSA activity, let me show you first something that is of great interest of Ceftaroline. This is the beta-lactam, Ceftaroline, or whatever beta-lactam you want. As you know, the beta-lactams are binding to the PVP of the Streptococcus pneumoniae by this serine and by a first non-covalent approach. Afterwards, there is a covalent approach through an acylation process, and finally, there is an hydrolysis. Of course, during this period, the activity of the PVP is inhibited, and this is what we want, the largest time the beta-lactam binded to the PVP. Well, this can be summarized in this enzymatic reaction, and this is regulated by some constants, constant of dissociation, of acylation, and hydrolysis. And of course, the better is that we have an antibiotic that has a very high constant of acylation, because doing so, the inhibition of the protein synthesis, of the cell wall synthesis of the pneumococcus will be early stopped, and then the antibiotic will be more bactericidal. From this perspective, it's very interesting to see which is the rate of the constant of acylation by the constant of dissociation of different beta-lactams. And as you can see here, Ceftaroline is 10 times more potent in terms of acylation than cefotaxime or even than penicillin. So we have nowadays the most potent anti-pneumococcal agent is indeed Ceftaroline. Even in those strains, these are susceptible to penicillin strains. But of course, the difference is even higher if the strain is resistant to penicillin. So there is an important difference in terms of the detailed mechanism of action of this new cephalosporin, that it's also transfer in terms of MIC, 4 times more potent in terms of MIC 50, and even 8 times more effective in terms of MIC 90 in comparison to ceftriaxone. So there is not only this point, but also another point. When we look at the beta-lactams, we know very well that beta-lactams are antibiotics that we say time-dependent antibiotics, because is the time the antibiotic remains over the MIC, so this period that is correlated with the bactericidal activity of the antibiotic. So what we need is to maintain a specific period of time over the MIC in order to be so active. We know, for example, that for cefotaxime, this should be 60% for strepto and gram-negatives and 40% for staph aureus. Well, which is this rate for Ceftaroline? Well, we have data from animal models against the staph aureus showing that only 30% of the exposure obtains a 3-log reduction in the total amount of staph aureus. So according to its mechanism of action, these antibiotics it provides a very potent bactericidal activity, even with less exposure time. This is, of course, different, making or explaining some of the results that we will discuss afterwards in terms of clinical outcome. But what about the Staph aureus? Why this antibiotic is active against MRSA? Just let me show you something that you know well. This is the synthesis of the cell wall of the Staph aureus. These red balloons are the PVPs. This is the PVP. Okay, here we have a transglycosylation process. And second, here we have a transpeptidation process. These two processes that are regulated by these enzymes, by the PVP2 in Staph aureus, in methicillin susceptible Staph aureus. Normally, this enzyme has in the middle this hole, and here an active serine. This active serine is responsible of entering these bricks into the cell wall. But if we look at this molecule, you will recognize a beta-lactam indeed is quite homologous to this dealanine. Dealanine, and for this reason is able to block the PVP, and by doing so inhibiting the cell wall synthesis. MRSA, what happens is that there are some minor changes in the new PVP that makes partial coverage of this hole, and now the beta-lactams cannot enter here. They are blocked here, yeah, but still the bacteria is able to introduce the dealanine. This is MRSA. This is some quite simplistic mechanism of resistance, but so critical. And I explained you this because if now we look at the PVP, this is again the PVP, but now in a 3 original dimension structure. And this is the active site. The active site where we find the serine at this point. Here we find the serine, and we know that beta-lactams have to enter here, but they in the active site, but in MRSA, it's not possible. However, what happens with Ceftaroline is that it's binding at a distal site from the active site, as you can see here, and by binding here, what it's inducing, the beta-lactam, this Ceftaroline, is a change in the conformational structure of the active site. And now this active site opens like a flower. These arrows indicates that the structure is open like a flower. And then this serine is now available for the entrance of another molecule of Ceftaroline here. By doing so, we have the first beta-lactam that is active against MRSA. Indeed, it's quite potent against MSSA and MRSA. Here you have the range for Staph aureus with a very potent MIC 50 and 90 for MSSA, even more than Cefazolin, that it's about 1, or Glucloxacillin, that is about 0.5. Active and quite active against MRSA with an MIC of 1, 50, and 90, and very active against other staph and streptococci pathogens, including also Haemophilus, influenza, and Moraxella as a part of the etiology, of community-acquired pneumonia. So from this perspective, I wanted to show you also, well, this is just to highlight this, to remember that also is at least similar to a third-generation cephalosporins against E. coli, against Klebsiella pneumonia, for example, but of course is not active against ESVL-producing E. coli or Klebsiella. Of course, these bacteria are also resistant to Ceftaroline. But saying that, I wanted to first describe some important aspects about the dosage in adults. In CAP is 6 milligrams every 12 hours infused in preferably 60 minutes. And complicated skin and soft tissue infection, that is another indication. Here you can use fusing in 60 minutes every 12 hours, also 600 milligrams. And there is a possibility, and it has been tested with a well tolerability, the administration of 600 milligrams every 8 hours, infusing in 120 minutes. Okay, these are the potential different dosages, and it needs an arrangement, adaptation when the patient has renal impairment. And here I'm showing you which are the renal adjustments that are mainly maintaining the same administration period every 12 hours, but reducing the dosage in every different strata of the creatinine clearance. Relatively recent news about Ceftaroline, that it's approved for pediatric patients. This is a really good news, I think, because in pediatrics, unfortunately, there are no new options for treating, for example, coagulase negative staph that always need vancomycin with all the problems associated with vancomycin. But now for pediatrics, we have an alternative, and these are the dosages for this particular population. What about the clinical studies? I'm not going to enter in all the details, but those clinical trials related with community-acquired pneumonia, mainly FOCUS 1 and 2 and Asia-CAP, I will discuss a little bit in more detail. These canvas are for complicated skin and soft tissue infections as covers, and CAPTURE is a registry. It's not a clinical trial, but it's a retrospective analysis. FOCUS 1 and FOCUS 2 trials were two trials that were quite similar in patients with community-acquired pneumonia with port 3 and 4, 1:1 randomization to Ceftaroline every 12 hours, 600 milligrams, or ceftriaxone 1 gram every 24 hours. And clinical recovery was the major endpoint, measure a test of cure, and also at last follow-up visit. This is mainly the structure, and these are the results. I wanted to focus you on the combination of both studies, and as you can observe here, in terms of the clinical cure, a test of cure, the patients that receive Ceftaroline, Synforo, had a significantly higher cure rate than those that receive ceftriaxone. And this difference, as you can see here, with an odds ratio of 6 and with an confident interval that is over 1. And in terms of the MITT population, as you can see here, but the same results for clinically evaluable population. However, what happens with this study, before entering in some comments, I wanted to remark that the sub-analysis of patients that had bacteremia secondary to pneumonia had a quite impressive better outcome in Ceftaroline arm than in the ceftriaxone arm. So probably supporting the idea that in patients with bacteremia, that are patients in more severe conditions, the Ceftaroline works better than ceftriaxone, and probably because of the mechanism of action that we have been discussing before. What was the limitation of the FOCUS 1 and 2? Well, maybe the dosage of ceftriaxone. 1 gram, it was suggested that it was not enough, and Asia-CAP was addressed to solve this question, and they compare with 2 grams, almost the same study, but 2 grams of ceftriaxone. And again, and even more difference, the clinical cure rate of the CE population was better in the Ceftaroline arm than in the ceftriaxone arm. As you can see here, the difference was significant in favor of Ceftaroline. So apparently, all this mechanism of action, lower MIC, more potent bactericidal agent, even with less exposure, has a clinical relevance in terms of better improvement of my patient. This is just the meta-analysis, just to show you how these articles combine, FOCUS 1 and 2 and Asia-CAP together. It's evident that the clinical cure was better. But I wanted to show you something that I think is of great interest. This is a post-hoc analysis of the FOCUS trials. They wanted to evaluate how fast the population that receives Synforo versus those that receive ceftriaxone improves earlier or not during the treatment. And in order to do so, they use the criteria that we described before that define the clinical stability, and also the criteria that they define as a clinical response. So clinical stability and clinical response that adds at least one symptom improve and no deterioration from baseline. So it adds to the physical examination some clinical data from the subject that is ill. And we define clinical stability and clinical response. Well, after adjusting in this paper, taking the data from FOCUS trials, and adjusting after age, sex, religion, prior pneumonia, alcohol abuse, prior antibiotic therapy, and the Porter scale, I mean, the most important and relevant factors associated with the outcome of my patient, the clinical to stability was significantly better in Ceftaroline than in ceftriaxone. Indeed, at any time from day 2 to day 7, and 80% more patients in Ceftaroline arm achieved clinical stability. So the stability was achieved earlier and faster in the Ceftaroline arm, again, supporting, and the same for the time to being dischargeable, more or less the same data, supporting the in vitro data is translating into the clinical data. But what about the Staph aureus, particularly during influenza season? Because I think that here is one of the major advantages of Ceftaroline. Indeed, we know that in influenza season, Staph aureus increases progressively. This is data from Spain during influenza season. Pneumococcus is still the most important and most common one, but it remains stable during the last years. So Staph aureus is very important pathogen because it is associated with a more severe infection. And as I mentioned before, the activity of Ceftaroline against MSSA, it's very, very interesting, even more potent than Cefazoline, for example. Also quite active against MRSA and also quite active against coagulase-negative staphylococci. Okay, this is something that we have mentioned before. What about the animal models? This is a Staph aureus rabbit pneumonia model, and a Staph aureus that is producing PBL, pentovalentine leukocidin producing staphylococci. We know that this staphylococci is very aggressive and they kill all the animals that are wearing the control arm. They kill the majority of the animals that were treated with vancomycin. As you can see here, the mortality rate was so high. Linezolid was clearly better, Ceftaroline better, and as good as clindamycin. This is very interesting because we know that clindamycin and linezolid are inhibiting the production of toxins by Staph aureus, and particularly PBL. And this is the reason why we understand that in these models, clindamycin and linezolid perform significantly better. But why Ceftaroline also performs significantly better? We know that beta-lactams are not stopping the production of PBL. However, it's interesting to see what happens in terms of the total amount of bacteria in the lung or in the spleen. And as I would expect it, Ceftaroline was the one associated with more potent bactericidal activity among all the other options. Yeah. And interestingly, also, the total amount of PBL in the lung was lower in the Ceftaroline arm than in the vancomycin arm, for example. And it was similar to the clindamycin arm. Why? Well, my hypothesis, and this is just an hypothesis, is that because of the very potent bactericidal activity of this new beta-lactam is the one that is responsible of this low amount of pneumolysin or PBL in case of a Staph aureus. Probably it's because of this very fast mechanism of action. Remember, the ceftriaxone, this is data for ceftriaxone against Staph aureus, as you can see here. And what you can observe is that the MIC50 is in 4 milligrams for at least 60% of the strain. So it's not a good and potent anti-staphylococcal agent. Indeed, ceftriaxone is a bad anti-staphylococcal agent. If we analyze in terms of pharmacodynamics, considering an MIC of 4 and even 2 grams of ceftriaxone infused in 30 minutes, the percentage of the patients that achieve the target, that it is at least 50% of the time over the MIC, is only 60% of the population. However, for an MIC of 1, the percentage of the patients that using this dosage of Ceftaroline achieve the target that we need, that is at least 30% of the time over the MIC, is 100%. So an important difference between these two antibiotics in terms of pharmacodynamics against Staph aureus. And this is again observed in the clinical arena. This is the meta-analysis that I'm showed you before. And here, the outcome according to the pathogen that it was isolated. And as I mentioned, it was a difference 10% higher for pneumococcus, for example, 12%. This is the cure rate for ceftaroline, cure rate for ceftriaxone. Also 10% or about 10% for E. coli, about 8%. Almost the same for Haemophilus influenza. Almost 17% for parainfluenza. For Klebsiella, 10% better. But what I wanted to highlight here is what happens in Staph aureus. As you can see here, for Staph aureus is the major difference. More than 20% better for ceftaroline than for ceftriaxone. Of course, even in the ceftaroline arm, the success rate was lower in Staph aureus than any other pathogen, because Staph aureus is a very severe pathogen. But it's clear that it's significantly better than ceftriaxone because this is a more potent antistaphylococcal agent. So just to conclude, empirical treatment for severe CAP, according to the guidelines, is it could be a macrolide or a fluoroquinolone. In my perspective, I prefer a macrolide plus a beta-lactam. And according to the clinical trials, ceftaroline apparently superior. Second, ceftaroline is 4 to 8 times more active than ceftriaxone against pneumococcus. And the clinical trials in patients with POR 3 and 4 ceftaroline had a higher clinical cure rates. Third, the co-infection with influenza viruses is an area where Staph aureus is so prevalent. And ceftaroline offers in this situation an excellent activity against not only pneumococcus, but also Staph aureus. And therefore, in this situation, I think that the association of ceftaroline with a macrolide would be, in my opinion, the best first-line option. Thank you very much for your attention. And now we have time for all the questions and discussions and comments that you want.
Hi, Dr. Alec. We're just waiting for Dr. James.
Okay.
Okay, ako na. Okay.
Hi, Dr. James. Can you hear us?
I don't have video.
You can open your camera, your camera po. Or
Na-open ko na video ko.
okay, Lucy, can we check on the panel of Dr. James? Dr. James, we can hear you, though we cannot see you, but I think we can proceed. Dr. James?
Yeah.
Okay.
Can I just talk?
Yes, we can proceed, though we cannot hear you, but it's okay. I think we can proceed. Dr. Alex Soriano is also here. Good afternoon, Dr. Alex. Dr. James?
Good afternoon.
Yes, please.
Okay, so good afternoon, colleagues. Welcome to this symposium on Pfizer with the title of Ceftaroline in Combating Community-Acquired Pneumonia. First of all, I would like to congratulate the organizers of this convention for a well-prepared one. And I'm Dr. James Chu. I'm going to moderate this session. You have just heard Dr. Alex Soriano's talk about Ceftaroline in combating community-acquired pneumonia. Dr. Alex Soriano is the head of infectious disease department in the Hospital Clinic of Barcelona in Spain. He is also a leader in the nosocomial infection group, August Pi Sunyer Biomedical Research Institute in Spain. He is a specialist in internal medicine and has a PhD from the University of Barcelona. His scientific contributions are focused more in the treatment and management of bacteremia, infections in the intensive care units, and infections related to orthopedic implants. He has more than 200 articles in national and international journals with more than 7,000 citations. And so that's Dr. Alex Soriano. Let's now go to the Q&A portion. If you have any questions, just type it on the chat area portion. There have already been some questions that have been submitted earlier. Okay, Dr. Soriano, here's the first question. Are there any known drug-drug interaction with Ceftaroline?
Well, first of all, thank you for the invitation and the introduction, Dr. James. The question, clearly, there is no important interaction. I mean, Ceftaroline is like any other cephalosporin in terms of metabolism and interactions, as, for example, ceftriaxone or ceftazidime. So there is no important interaction.
Okay, thank you. Another question here. You presented that the indication for Ceftaroline is that for SSTI or soft tissue skin infection and for CAP. How about primary bacteremia?
Well, this is a good question. There is no indication for bacteremia. The drug has no this indication, and I don't know if in the future it will be any indication. I mean, a formal indication. But the real thing, if you ask me about the potential of this drug for treating staphylococcal bacteremia, or for example, pneumococcus bacteremia, those patients that had CAP and had bacteremia by pneumococcus, the experience from the literature, from the clinical trials and some observational studies suggests that it works quite well. Yeah, and indeed there is data, even a clinical trial, very short clinical trial, showing that the combination of ceftaroline plus daptomycin indeed is a very potent bactericidal combination against the Staph aureus, particularly MRSA. And as I mentioned, this clinical trial compares this combination with vancomycin, and the mortality was significantly lower in the combination with ceftaroline plus daptomycin, but the trial was stopped by the ethical committee because of the difference in mortality. And finally, there were very few patients in each arm, but of course, it's something that is under debate, which is the impact of this clinical trial.
Okay, thank you for that, Doctor. Here's a question from the chat portion. what type of cephalosporin is ceftaroline? Is it a third generation, fourth, or fifth generation? And are there studies right now for its use in patients with meningitis?
Yeah, well, about the generation, yeah, I think that the most common description is that ceftaroline is a group of fifth generation cephalosporins. What it make the difference with in order to be in a different group, is that are the first beta-lactams that are active against MRSA, no? And this makes this particular cephalosporin in a different group. In terms of the experience with meningitis, of course, it's an attractive drug as a very potent antipneumococcal agent. Is a very attractive drug for meningitis, particularly if we know that the resistance to penicillin in pneumococcus, when we use the cutoffs for meningitis, unfortunately, is relatively high. I mean, more than 20% of pneumococcus strains are resistant to penicillin, according to the breakpoints for meningitis, yes? And so it would be very attractive to have a new cephalosporin with this potent activity against even resistant pneumococci. However, I want to mention that the clinical experience is quite short. There are 4 cases in an antimicrobial agents and chemotherapy published about 2 or 3 years ago. The 4 cases, 3 were treated with 500 milligrams every 8 hours, and they had a good outcome, pneumococcus meningitis. And the 4th case had a bad outcome, but it was treated with 500 milligrams every 12 hours. So the diffusion of ceftaroline to the spinal fluid is exactly the same as, 5%, 10% as any other beta-lactam, probably in inflamed meninges, probably a little bit higher, up to 15 or 20%. But the problem or the difference between ceftaroline and, for example, cefotaxime or ceftriaxone is that we are using 4 grams of ceftriaxone or 24 grams of cefotaxime. But with ceftaroline, that of course is a significantly more potent probably, but we are using 1 gram, 1,800 milligrams. I mean, we cannot increase the dosage because we don't have experience with higher dosages, although we can expect that probably no more adverse events, but there is no data. So of course, if we have a very resistant pneumococci, when we isolated the pathogen, ceftaroline could be an option, but there is still few data. And of course, the relatively short dosage for meningitis is something that makes me a little bit concerned.
Okay, thank you for that. Now, in giving your ceftaroline, do you have an experience of giving it for a 24-hour period infusion time?
Well, this is a nice question, and we always support the continuous infusion of beta-lactams in general. To be honest, I'm not aware of any data using the drug in this way. And now I cannot remember data on stability at ambient temperature, but probably it is stable. If we administer the drug every 12 hours or every 8 hours, the real thing is that the half-life, and according to the MIC, we are able to achieve, as I mentioned in my lecture, the targets that we need to obtain the bactericidal activity, the pharmacodynamic targets. But so theoretically, with the current dosage, at least for pneumonia or for skin and soft tissue infections, would be enough. But if we want to infuse, well, it would be probably okay. But I don't have exactly whether the stability at 24 hours at room temperature is already there or not. But probably it is. As any other cephalosporin.
Okay, thank you. We will note about that. Okay, this will be the last question, unless there is another one in the chat. With regards to MRSA, what would be the advantage of ceftaroline over vancomycin?
Oh, this is a great question. Definitely, we are using less and less vancomycin for MRSA. Vancomycin is a slow bactericidal antibiotic. Our experience and the experience from the past clearly shows that vancomycin, probably because of this slow bactericidal effect, probably because the dosage that we have to use, particularly in patients with severe infections, it should be very high from the beginning. I mean, we need to obtain a high exposure from the first 24 hours in order to improve the outcome of patients with MRSA infections. And this is very well described in the literature. And according to that, we know that when we use vancomycin for Staph aureus, for methicillin susceptible Staph aureus, the outcome is worse than if we use a beta-lactam. I mean, cloxacillin, flucloxacillin, this is something that everybody accepts. No? I mean, if you have a methicillin susceptible, use always a beta-lactam, never vancomycin, because we know that vancomycin is worse, according to observational studies. So nowadays, we have a beta-lactam that is active against MRSA. So it's more than reasonable to expect that the activity of this new beta-lactam would be, of course, better than vancomycin. So from this perspective, and considering also that vancomycin, when you use at high dosages that are necessary, particularly for severe infections, for more than 5-7 days, the rate of nephrotoxicity is also relatively high, more than 10-15%. And a beta-lactam, like ceftaroline, has no renal toxicity. So,
okay. Thank you.
So in my sorry.
Okay, go ahead, Dr. Soriano. Go ahead, Dr. Soriano.
No. Just to say that just to say that in my opinion, according to these advantages that I mentioned, definitely nowadays ceftaroline is better than vancomycin. Indeed, I would not use vancomycin anymore because ceftaroline is a beta-lactam active against MRSA. I think it's better.
Okay, with that, we would like to thank Dr. Alex Soriano for his talk. Can we now go to our president, Dr. Marisa Alejandria, for the closing remarks? Dr. Alejandria, please.
Thank you, Dr. Alex Soriano, for your informative talk, for sharing your expertise and updating us on effective antibiotic regimens for community-acquired pneumonia, with emphasis on the PK/PD of ceftaroline and the clinical trials on the use of this antibiotic. Thank you also, Dr. James, for facilitating the discussion. And Dr. Alex, thank you very much for gracing our annual convention. On behalf of the board...
Thank you for inviting me.
Yeah, it's our pleasure and privilege. On behalf of the board of the PSMID, I would like to thank Pfizer for your continuing partnership with PSMID through the years, and most especially on this historical year of our 42nd annual convention. Despite these challenging times, we deemed it necessary that the scientific lessons we will impart in this convention should be communicated now more than ever. And your loyal partnership in this endeavor has helped us make this virtual convention happen. We shall be sending the certificates of appreciation for Dr. Alex Soriano and Pfizer by email. I'd like to thank all of you for attending this afternoon's lecture, and we look forward to seeing you in the main scientific sessions immediately following this. So we'll have a panel discussion at 5 p.m. On the performance of our government in this pandemic. So please don't forget to exit this Zoom webinar room and click on the evening session Zoom link on the convention website. Have a good day, everyone. Thank you.
Thank you.